The major viscera of the abdomen under the following headings: anatomical position, external and internal features, important peritoneal and other relations, and blood supply, nerve supply, lymphatic drainage, and applied aspect. Explain the anatomical basis of lymphatic spread in carcinoma of the stomach. Location. The stomach occupies the left hypochondriac, umbilical, and epigastric region. Most of the stomach lies under cover of the left costal and margin and lower rib. See, most of the thing. It is here. So, if there is any pyloric stenosis, then you lie the patient in prone position like this. If any obstruction in the outlet obstruction due to carcinoma or due to pyloric stenosis, the scope cannot pass through it. The patient comes in, but they are taking food, again vomiting, and the patient most are cachectic. Cachectic means repeated vomiting. He will lose his weight. Then you have to think, and also you open up the shirt and your see the neck. না একটা ভদ্রমহিলা এসছে তার সব খুলে দিতে বলবে তা নয়, হ্যাঁ না এটা খুলে ফেলুন, no. So you have to see if there is a gland over here, the Varshos gland. That means the spread is there in the neck. Is if the stomach is having a big growth. Also, a newborn can have a congenital defect of the outlet of the stomach, that is the pylorus. So nowadays the pediatric surgeons, they do pyloroplasty. That is now, of course, now in big hospitals they'll do a pediatric gastroduodenoscopy to see what is the exact pathology and narrowing, how much narrowing is that. Now, these are circular muscles. Now, congenital, or you see, you make an incision like this. Then you suture it. So it becomes tube. Now, if it is, make an incision like this, then the thing width increases. This is one. But if there is a growth in this part, there are numerous types of operations in the stomach, jejunum and duodenum. Numerous operations. Now, if a patient is old, you cannot do major surgery like part of the stomach is cut, okay, and the jejunum is anastomose, a bypass. There are numerous operations. When you go to surgery, you will be reading on it. Okay. Now, the thing is that the stomach is usually J-shaped, called asthenic and normal type. Now, one thing is that the stomach, when you get an opportunity to see it in the clinic, still you will get it, growth. Recently, I think 3 months back, I sent a patient to Professor Sumit Sannal. He's a wonderful surgeon and young surgeon, and he did the operation. I send many major surgeries now to the Santiniketan Medical, many emergencies to because institution. Now, what he did this partial gastrectomy, and then he was having some problem. So I told him, then you go and show him the problem. But what is there, if it is say 6 months old or some, then they do a GI endoscopy, because to see the stomal size, if there is any growth in that region, so there can be obstruction. Or for this type of condition, you ask for a routine stool examination to see occult blood. In the stool, after the occult blood, you prescribe, you write occult blood. It can happen also in normal conditions, occult blood due to worms, ascaris and all this, hookworm and all this. So that will give you a picture of the condition of the stomach, one thing. Another is your gastroduodenoscopy root. Now, it was being thought in the earlier days that due to some vagus, so the hyperacidity is there and there was ulceration. No. Now, it is the concept has changed, that H. pylori bacteria. So, you have to give a course of antibiotics and all this. Now, to get him cured. And now, this is the relation of the stomach with peritoneal relation. The stomach is lined by peritoneum on both surfaces, except where the vessels run along the curvatures and at the bare area of the stomach. Now, bare area of the stomach, it is a small area that is devoid of peritoneum and comes in direct contact with the left crus of the diaphragm. It is located near the cardiac end on the posterior surface. Now, I was telling you that your pyloric stenosis, you will be, I told you earlier that the food you take, intake of shag or something like that, the history will reveal there is some obstruction. Okay. Another thing is that if the patient is not operable, at least do a bypass or gastrostomy, feeding the patient, because they won't die. মানুষের জীবন খুব কঠিন, they won't die. So you have to plan and opt for your bypass. Just a simple thing. In earlier days, when I saw do gastrostomy, and one lady, she was so cacactic. I did it under local anesthesia. I blocked the rectal sheath, and after sedation and analgesic, I just opened the stomach, put out the stomach, the jejunum. I put my hand and slowly palpated, calculated from the duodenum, then jejunum. From there, 6 inches, 12 inches, and then I took the jejunum out, stomach, I did a bypass. This is to relieve her of the vomiting and all. But nowadays, you definitely anesthesia, your spinal anesthesia. Now, the sites you could not imagine, a surgeon penetrates there also. And of course, there are different, this thing. Now, this is one thing, the folds of the peritoneum extends from the stomach. Now, the lesser omentum extends from the lesser curvature of the liver, and greater omentum extends downwards from the greater curvature, greater omentum, and gastrosplenic ligament extends from the upper part of the gastric curvature to the spleen. The gastrophrenic ligament extends from the fundus of the stomach to the diaphragm, this part, and fundus of the stomach of the diaphragm. Thus, the greater curvature of the stomach gives attachment to gastrophrenic ligament, gastrosplenic ligament, and greater omentum from above downwards. This, when you see the body bar করে দিয়েছে, ঠিক আছে, whatever it is, you please see and you see the orientation. ওই একবার ঘাড় থেকে দেখে নাও, আমি তো সার্জেন হব না, নো, you will be an MBBS, then you do your MCH, whatever it is, it's up to you. Now, you please note that yeah, the hepatogastric ligament, hepatoduodenal ligament, this is duodenum, the diaphragm, gastrophrenic ligament, gastrosplenic ligament, spleen, this is the spleen, and the greater omentum. ঠিক আছে, বলি সেটা হচ্ছে these content, stomach যখনই ধরবে, whenever you ask to take the viscera of the stomach, then these part you just remember. This visceral relation, the posterior surface, as your stomach bed. Even it is a theoretical questions come, and also Viva and also gold medal award. স্যার ডেকেছিল গোল্ড মেডেল পরীক্ষার ব্যাপারে, ঠিক আছে। নাও whatever I'm stressing you, I'm telling you the examination point of view, I'm telling you, repeating it, তোমাদের মনে হচ্ছে যেন ঠিক ভালো লাগছে না, ঠিক আছে, উপায় নেই, একই কথা বলছি, কিন্তু তোমাদের এই 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 ছবিটা দরকার তোমাদের কাছে আছে, you take it in the phone. Now, posterior surface, stomach bed, spleen, diaphragm, left suprarenal gland, left kidney, splenic artery, pancreas, left colic flexure, transverse mesocolon. Now, if you go back, it is more on the left side. Stomach is more on the left side. Then, what are the possible structures in the posterior end? মুখস্থ করার কিছু নেই, হ্যাঁ, you just see the relation. रटना है लेकिन क्या बोलेगा, रटो, थोड़ा होशियारी से रटो. Now see, now what I want to stress is, see, this is the midline, if you say. Then the stomach, that organ, every organ is important. Stomach is like a king. ও সব খাবার খায়, ডাইরেক্ট কন্ট্যাক্ট উইথ দি ফুড। এই ঠান্ডায় আইসক্রিম খেতে ইচ্ছে হচ্ছে, হ্যাঁ, একটা লেমনেড খেতে ইচ্ছে হচ্ছে, একটা কুলফি খেতে ইচ্ছে হচ্ছে, তো হি লাই ডাউন লাইক দিস ইন দি বেড. Now what are the beds? This tissue, your comprises of the again I'm telling you the structures on the left side of the median. You just see your spleen, the diaphragm, the left suprarenal gland, the left kidney, splenic artery, pancreas, left colic flexure, transverse mesocolon. When you see the dead body in the in situ, you will just lift up the greater omentum, lift up the stomach, and you see the organs. You see, when you lift up the greater omentum, you see the transverse colon, left colic flexure. You just sit down and you draw a figure. You draw a figure of the stomach, its anatomical position, plus your what is location, body's GPS. So where one by one, the organs are placed there. What are the organs? ডান দিকে স্প্লিন হবে না, বাঁ দিকে স্প্লিন, লাইক দিস। ইউ লেফট কিডনি, লেফট সুপ্রারেনাল গ্ল্যান্ড, লেফট কোলিক ফ্লেক্সার, এরকম করে দিই, ডায়াফ্রাম। মানে আমি তোমাকে জাস্ট telling you the methodology of remembering. It really, it was when we had no notes, no books. Books, of course, we had grace, but we had 2 years time. I'm telling you, you just sit down. Now, stomach, keep all, see, lymphatic drainage of the stomach. Lymphatic drainage is very important. And see, now the anterior surface. What the anterior surface is? Left lobe of liver, quadrate lobe, diaphragm, anterior abdominal wall. Peritoneal relations, peritoneal ligaments, lesser omentum, greater omentum, gastrophrenic ligament, gastrosplenic ligament. This. ঠিক আছে? Now your visceral relations. These are the visceral, these are peritoneal relation. Now, I won't go into the details of this. Now, these are the terminology, gastric triangle. It is a triangular area of the stomach that is in contact with the anterior abdominal wall. It is bounded on the left by the left costal margin, on the right by the inferior border of the liver, and inferiorly by the transverse colon. Then your viscera, that what I told you, when you see, please, I'm telling you, once the body is placed there, you please see, the dead bodies are really wonderful. Even you revise your thorax there. The heart, it is so, now gastrostomy is a surgical insertion of a tube in stomach. It is performed through the gastric triangle to feed the patient in case of esophageal obstruction. You cannot take like Barrett's esophagus. Now, any growth in the esophagus, then this is not very commonly performed. These surgeries, cardiothoracic surgeon, a team, plus your general surgeon. When there are places that they are performing, but how much? It's a number, সারা ভারতবর্ষে হয়তো 50টা জায়গায় হয়। So similarly, you have to know that what is the gastric triangle. So, and gastrostomy, surgical insertion of the tube in the stomach in this level. You can open up under anesthesia. Okay. And you put a feeding tube. Now see, write short notes on stomach, bed, same repetition. Now you can see the now blood supply, lymphatic range innervation. Now left gastric artery, right gastric, left gastroepiploic, right gastroepiploic, short gastric arteries, and posterior gastric artery. You know this. Now branch of left gastric, celiac trunk, branch of common hepatic artery, left gastroepiploic, branch of the splenic artery, right gastroepiploic artery, branch of the gastroduodenal artery, and short gastric arteries, 5 to 7 in numbers, branch of the splenic artery, posterior gastric artery, branch of splenic artery. Now, now see the arterial supply here. In the dead body, if the stomach is there, you can see it. দেখে নেবে। আর when you get an opportunity, একটা গ্লাভস পরে তোমাদের যদি যখন অবজারভার হিসেবে দেখা যায় তখন একবার দেখে নেবে যে সব অল পালসেটিং। Gastric, right fluid, short gastric, posterior gastric, venous drainage, innervation, sympathetic fibers. This level, I told you the other day, the level at which level the sympathetic is T6 to T10. Now, and parasympathetic fibers, anterior and posterior vagal trunks, causes vasodilation, inhibitory to pyloric sphincter, hunger, sensation, nausea. Now, venous drainage, left gastric vein, right gastric vein, left gastric epiploic vein, right gastric vein, short gastric vein, posterior gastric vein. Now, for your আপনাকে 60% দিয়ে দিয়েছি, there are some clues that he is answering well, then they will ask you the detail. তোমাদের মধ্যে তোমার ছেলেদের জিজ্ঞেস করবে, কিছু না কিছু ছেলে মেয়ে নিশ্চয়ই পড়ছে, কিন্তু তোমার যদি মনে হয় আমি অত লড়াইয়ে থাকবো না, আমি অত টেনশন করবো না, আমি 60 নম্বরে খুশি, ডোন্ট কিল ইয়োরসেলফ। তুমি যদি একটা অ্যাভারেজ চিন্তা ভাবনা করে চলো তাহলে কিন্তু তুমি কমফর্ট জোনে থাকবে, কিন্তু তুমি এটা করতে গিয়ে ওটা করতে গিয়ে এটাতে মানে excel করবো, you'll kill yourself. Don't. Now, what I want to do, the basic, know what is the stomach, liver, colon, your pancreas, kidney একটা ট্রেতে থাকছে, তোমরা তো দেখেছো। তো সেখান থেকে তোমাকে তুমি যদি কনফিডেন্ট থাকো বলুন, তাহলে তুমি বলবে। Why you lose a chance? You say, but these are the places of the stomach you have to focus. The stomach bed and your arterial supply, your venous drainage and lymphatics. Now you see the venous drainage. If I write a book, I'll never write a book. If I write a book, in anatomy I won't write, but other books I might. But why I'm telling you, this is the same picture you get it in McGregor's anatomy. Okay. Now we write a book, we'll take McGregor as a base. So don't search for all this and download and moja korar jayga nei. You just be focused. Stomach, you draw a figure today. Stomach bed, you just go finish today. Stomach finish. They have tied a thread in the pyloric side, but that thread won't be there or might not be there, should not be there. But you see the shape. Now I cannot turn like this because this is right side pyloric end like this. You hold it like this. The midline, you hold it like this. Like this. তুমি এরকম, when you asked to ট্রেতে দোলো, now if I lie down, I become prone, then you will see the relations of all the organs over here. 1, 2, 3, 4, 5, 6, 7, 8. You hold it like this. Greater curvature, lesser curvature. Now, এটা কিন্তু তোমরা যখন একসাথে পড়বে তখন আর you do one thing, একটা cardboard means poster paper or something, একটা ড্রয়িং করে নিলে কাঁচি দিয়ে কেটে নিলে, তোমরা 4 জন পড়ছো, you hold it like this. এই বল, and this is the greater curvature, this is the lesser curvature, যাই হোক আছে descriptive. Now this is lesser curvature, this is greater curvature, this is the pyloric end. হ্যাঁ, In what level? Stomach bed. What are the your arterial supply? You open your book. একবারে দরকার হলে একটা শতরঞ্জ পেতে দেবে, ম্যাট পেতে দেবে, দিয়ে বসে যাবে একবারে বসে, তার মধ্যে একটা কুশন রাখবে, একটা বালিশ রাখবে, টায়ার্ড হয়ে যাচ্ছ ধরে বসে থাকবে। ডোন্ট ইগনোর। আর এরকমভাবে হবে না পরীক্ষা। যত দিন যাচ্ছে তার পাশের হাড় ফেল করছে অনেক বেশি। প্র্যাকটিক্যালতে যা হলো তাও আমি বলবো বি প্রিপেয়ার্ড, because you are given a choice. Main thing is that in our time we are not given a choice. And 3 students or 4 students ভাইবাটা হচ্ছে। But the examiner knows যে কে পড়েছে কে পড়েনি। ডোন্ট থিঙ্ক যে ওটা তো ডামাডোলে আছে, আমি গ্রুপে থাকবো, গ্রুপে থেকে নম্বর হয়ে যাবে। In subconscious mind, if something is going into yourself, এটা তো আছে, এটা I'll manage. Now, you make a নিয়ে আসবে ছোট ছোট এমনি কালার্ড পোস্টার পেপার্স। You go to the market, you go to Chandra Supply in Chomata, that is going to Santiniketan Road, in that corner, a stationery shop, oldest stationery shop. And if you want to enjoy some that evening, you go to Ratanpalli, Rajada's shop. You have momo and all this, you have beautiful coffee, adda, but I won't be speaking. You have many substances to take, that is, you will be abusing yourself. গাঁজা ফাজা সব পাওয়া যায়, কিন্তু ডোন্ট। আমি এত অপারেশন করেছি, এত স্ট্রেসের ভেতরে থাকি, আই নেভার স্মোক, আই নেভার ড্রিঙ্ক। ওকে, নাও হোয়াট আই এম টেলিং ইউ, ইউ মেক আ মডেল, মানে একটা অ্যান্ড স্টাডি। ইউ ড্র একটা ইয়েতেই তুমি ধরবে এরকম করে, প্র্যাকটিস, একটু প্র্যাকটিস করবে, কারণ ইট ওন্ট বি লাইক লুকিং হোয়াট আমি কি দেখছি। লিভার, ইউ সি, ইউ মেক আ লিভার স্ট্রাকচার। এবার এখানেও তোমরা যেমন থাকছো না কেউ, নো ওয়ান ইজ স্টেইং। আমার বলা বৃথা। প্লিজ, আর কমান্স 4 না 5 6 মাস, তারপরে কি, বাট 5 মাস হলো, 5 মাস। In between, see, many repetitions are going in this class. Many repetitions. And you are seeing this, আজকে যাব না। So, lymphatic drainage, this is very important. The celiac nodes, hepatic nodes, right gastric node, left gastric node, pancreatosplenic node, right gastropyloric node. Now it is if you go and draw this diagram, then it is easy to say, see the stomach, I told you the location and the stomach bed, but what are the nodes? Normal condition, the nodes are there. So nodes, these nodes on the, now you see, when you see the celiac, the vessels, then you will be getting their branches, and the nodes are there. In normal condition, you will be seeing small nodes, but if there is any your some disease, some growth, you might find large nodes. Malignancy, carcinoma of the stomach, malignancy, you will find large nodes. Plus, in a remote area, when you see a person is having a neck gland over here, one solitary, which shows gland, it is in location is this. And you take the history. Now, kotha bolte bolte, now now when you are seeing a patient is lying on your examination table. You just look the neck. From neck you see if there is any node. But I might have some fat over there. So when you start palpating the neck, and from posterior end you palpate and you get a node. Now that can be, that I am not saying that every patient is having Visceral gland. It can be due to some upper respiratory tract infection or pathology, or some cough and cold. And most common is your tuberculosis. So tubercular lymphadenopathy. But that will be a chain of lumps. You feel it, the feel will be bit different. First, there can be a suppurating lymphadenitis. Suppurating with some infected pus-like material coming out. But one thing is that tubercular lymph nodes, now if this node is here, now this node is like this, normal shape. But if it is suppurating, then this material comes out. Now it will be like this. You can see the difference. But in malignancy, it will be nodular, it will be, you can palpate and see it is hard in comparison to tuberculosis, but that is also infective pathology, so there will be fibrosis, it will be quite moderately hard. But normal inflammatory condition is due to some tonsillitis or some other thing, the submandibular glands, this thing, the nodes over here, below the neck, then it will be soft. Soft means ekdam soft nahi. And see, now see this picture, you can make flashcards. Cards किने निले सादा सादा. Just make diagram or khata. You make a, okay. Now see the lymphatics of the stomach, the 4 lymphatic territories of the stomach. 4 lymphatic territories of the stomach. Your, say, West Bengal, Bangladesh, your East, Assam, Tripura, and these places are like this. Now that area, I told you, yeah. Now the area, this is the territory, this is the territory. These are the territories. See this territory, area 1, area 4, this drains into the celiac nodes, hepatic nodes, right gastric nodes, and this left gastric nodes. Now the area 3 is pancreatosplenic node. Now area 2, the right gastrophrenic node, pyloric nodes, right gastric nodes. Now imaging, modern imaging, and MRI, your CT, now these, you can see the image, again the remote, which part of the thing. So you can target your management and treatment of the right 2/3, upper 2/3 area 1, left gastric nodes, and lower to 1/3 area 4, right gastric and hepatic nodes. Left 1/3, upper 1/3 area 3, pancreatosplenic nodes, lower 2/3 area gastrophrenic nodes. Now previously vagotomy, the vagus nerve is to be cut. So what our teachers, surgeons, some wonderful surgeons I had the opportunity to be under. Now what they used to do was they make an incision like this, and take a rubber catheter and pull, assistant pulls, and slowly they palpate and cord like, and then see it. And they used to do, few fibers used to be cut. That operation, vagotomy operation, is obsolete now. It is a bypass operation or something like that, or medical treatment. But one thing, the chaos is that you see any Onustan Bhavan, you go to any marriage thing, this Onustan Bhavan means this, where marriage is now not in the house, বাড়িতে বিয়ে হয় না, আমাদের বাড়িতেই বিয়ে হতো, কিন্তু আমার মেয়েদের বিয়ে মোর কুটির, and these hotels are the thing we had. Now why I am telling you this, because see, your nerve supply and this thing, vagotomy, that can be vagotomy. Now in what conditions the vagotomy is done? Pyloric and there is an ulcer, and your main structures is that the vagus nerve. But today, after your duodenoscopy, you get H. pylori infection. Then you give a course of antibiotic and PPI. Now, what I was telling in the marriage hall, anyone comes, if there is a chemist shop, people will run, hey, there are Rantac, Gintac, Omens D, these are the, hey, Rantac janis na, Omens D ka, so you popping up your PPI. Now, these are the drugs that is being consumed. See, when you write a prescription, I just put O. ডাক্তারবাবু আমি ওমেজ খেয়েছি, আর if I write, ডাক্তারবাবু আমি র্যান্ট্যাক খেয়ে নিয়েছি, then you have to give something new. You have to prescribe in such a way that something different is being done. Just say for this peptic ulcer syndrome, okay, the gastric, the belching, your acidity, and your buk jala kurche, burning sensation. Now these things, what I do is that PPI you will give some, that even he is taken, hey, sort of, এটা আমার অন্যভাবে দেওয়া হচ্ছে, and go back to the old is gold, that is liquid antacids. Now, chronomedicine is with the timing of the clock. 7 a.m. 2 teaspoons, or 8 a.m. 2 teaspoons, 12 noon 2 teaspoons, 8 p.m. 2 teaspoons. Then that modifies. Then you give some your painkillers or something like that. Painkillers means that not ibuprofen or paracetamol or something like that. It is the antispasmodics, right? Dicyclomine, chloroperoxide, these type of drugs. You will read in pharmacology. But I am telling you the difference, that when you are observing any patient, you think it in this term, that our stomach related patient test. Next year, you will be there attending clinics. So you see and ask the question. There are 10 patients having 10 disorders, or it might be that 5 patients is having with gastric related problem, or acidity problem, or hyperacidity problem. you please, you can go now. You can go, and next tomorrow we'll meet again.